Hi everybody, Dr. A here. We're going to talk reproductive diseases and disorders for this chapter 25 of our clinical chemistry lessons. We're going to do a quick review of the female system. So components of the female reproductive system are the ovaries, the uterine tubes, also referred to as the fallopian tubes, the uterus, the cervix, and the vagina. In a female, the reproductive tract is separate from the urinary tract. They have two separate openings. And in the ovum development, so the beginning of the making of the eggs that are going eventually to be used for fertility, that starts when the baby girl is in her mom's womb as a fetus. That's the beginning of ovum development. Now this gets interrupted, so it stops at a certain point, and then it resumes at puberty. And what starts the cycle at puberty, or the female reproductive cycle, is going to be the beginning of releasing of gonadotropin-releasing hormones that comes from the hypothalamus, and that will start the release of the cascade of hormones that trigger the reproduction. And so if all goes well, then there will be ovulation. An egg will be produced every 28 days or so. And but if there's no ovulation, then it could be that there's a problem, there's a disease, or I mean, it could be that they're on birth control, there's something. So and then if there is no ovulation, then obviously fertility is going to be an issue. Also, ovulation stops at menopause, so wouldn't expect ovulation at that time, and ovulation doesn't start in puberty, so you wouldn't expect ovulation before that either. So let's take a little bit of time and kind of review everything that's going on in a female reproductive cycle. So again, initially the hypothalamus causes a release of gonadotropin-releasing hormone, and therefore that hormone is going to cross over to the anterior pituitary and cause the release of the gonadotropins. The gonadotropins are follicle-stimulating hormone and luteinizing hormone, also known as FSH and LH. Okay. So, under the influence of these hormones, the female cycle is going to take place. But which one does what? Follicle-stimulating hormone does exactly what its name implies, is it stimulates the development of the follicle to release the egg at the end of the follicular phase, which ends at ovulation here. So, follicle-stimulating hormone here is going to be higher in this follicular phase of the cycle. And again, its point is to develop follicles. Now, it takes actually 300 days to develop the follicle, so it's developing multiple follicles at the same time, and they're all the different types, different like times of development. But the idea is that every 28 days, one of them is ready to mature and releases an egg at ovulation. Ovulation is triggered by a spike in luteinizing hormone and a smaller spike in follicle-stimulating hormone. And that spike in luteinizing hormone then starts the luteal phase of the female cycle, where after the follicle has released its egg, what's left behind here becomes the corpus luteum. Corpus luteum, its job is to produce progesterone. Okay, and the luteal phase of reproduction, of the reproductive cycle, is to facilitate pregnancy, because obviously we have ovulation, we have a release of an egg, so maybe the egg gets fertilized, and so it creates all the ideal condition for pregnancy to occur. So let's look a little bit about what happens with estrogen and progesterone. Okay. So estrogen is always going to be higher in the follicular phase, and part of what estrogen does is it also helps build up and develop that follicle, and then it helps the beginning of building up this uterine lining. Okay, so it's going to build up that uterine lining, and then progesterone at this point in time is pretty low, right? And then after ovulation, progesterone is going to start spiking and go beyond what estrogen is. Estrogen, again, still remains pretty good up there because it still wants to maintain that uterine lining. So progesterone peaks here, and again, what it does is to make sure that this uterine lining is ready to receive the fertilized egg. So if there was fertilization that occurred here, the egg, when it's been released by the ovary, is all the way up at the beginning of the fallopian tube. And if the sperm is reached all the way up there in the upper third of the fallopian tube and fertilized egg, and the egg starts dividing and stuff, it's still going to take it an entire 7 days before it reaches the uterus where it can implant in the uterine lining. So we would be somewhere at day 21, 22, something like that, which is right here smack in the middle of the luteal phase with the highest progesterone. And then so if implantation occurs, then progesterone will continue to be produced to maintain the early pregnancy. And so this corpus luteum will stay and continue producing progesterone. So if no fertilization occurs, then what happens is once the body is basically looking for implantation here. And so after a certain amount of days, basically saying, okay, it's been so many days since ovulation, and obviously fertilization is not happening. So then all of a sudden progesterone is going to drop, estrogen is going to drop, and the lining is going to start atrophy, and then you're going to have the menstrual phase, which is the shedding of this lining that was built up so that it can start over and do it again for the next month. Okay, so progesterone is higher in the luteal phase, estrogen is higher in the follicular phase. Progesterone is really there to facilitate pregnancy. Estrogen is there to start prepping the uterine lining and to help facilitate ovulation here. Now, here's an interesting tidbit. If a woman is on hormonal birth control, what the hormonal birth control does is it uses synthetic progesterone and with some estrogen to mimic this phase right here, where the body is just kind of looking to see if the person's pregnant. It's this throughout the entire month. So it mimics this phase. And so even though when if it's a pill, take the 21 days, and then there's 7 days there's no pill, it's just a sugar pill, there's just nothing in there, then that causes artificially really that drop in estrogen and progesterone, and there is some bleeding, but it's really what they call breakthrough bleeding, because there never was a true building of the uterine lining, because there never was a peak of estrogen over progesterone, and then they just stayed in this like looking for pregnancy stage, and so it's actually not a true period, true menstruation. So other thing, a little tidbit that's interesting, is if a female is exposed to too much estrogen, especially via exposures to xenoestrogens such as BPA and other chemicals that are in our environment and our everyday, we expose to it every day, then you can overbuild this lining. And if you overbuild the uterine lining, then a female can have really heavy periods with a lot of heavy bleeding and cramping. So if there's heavy periods, heavy bleeding, there's possibly too much estrogen in the body. So the male system and normal function. So the male shares reproductive and urinary structures in the urethra, where they merge together for a common exit. The gonadotropin releasing hormone begins the process of becoming reproductively mature for a male. Same thing as a female, starts at that process will start at puberty. They also really the beginning building of the sperm stem cells, if you will, happens in utero when the baby boy is in his mom's womb. Then it stops, and then later on it resumes at puberty. And at puberty, when gonadotropin releasing hormone begins the process of reproductive maturation, luteinizing hormone LH here, which is again named for what it does in the female body, but it stimulates testosterone production. So as LH goes up, testosterone goes up. And then testosterone pairs up with follicle stimulating hormone to initiate the spermatogenesis to make sperm. And this is also on a negative feedback loop, meaning if there's enough sperms that are made, then there's the negative feedback will tell it, okay, we don't have to produce any more, but then if they all leave the body, then we got to produce some more. And so there's a negative feedback loop system to control that. So interesting, some of the effects of testosterone in men. So we have obviously what we just talked about, sperm production. And do note that in here sometimes estrogen is involved. So this is estradiol here, and dihydrotestosterone and estrogen here. So pubertal development, puberty, so that the presence of testosterone is going to facilitate that. And some of the things that it's going to do, for example, in puberty is going to be facial hair growth, the prostate will develop and grow, sebum formation, so their skin all of a sudden get oily, they may get acne and stuff. It'll develop the penis, scrotum, urethra, prostate, all of that. It does, intrauterine differentiation, right? So the presence of testosterone in the uterus then is the signal for the embryo to develop into a male. So it facilitates development of the male reproductive structures. And so it is on a feedback suppression of the gonadotropin secretion. So there's again that negative feedback loop. Testosterone also imprints the male pattern of the gonadotropins, sex drive, and behavior. So being exposed to enough testosterone in utero will cause a boy to develop into a typical male, and with the typical male behaviors, if you will. If there's more, let's say, estrogen, then that male may, instead of developing typical male behaviors, they may develop some female behaviors also. So this mix of how much testosterone and estrogen a fetus is exposed to can really do a lot to drive behaviors, and so that are usually typically associated with one sex or the other. It will also do, of course, at puberty, the larynx development, the deepening of the male voice, that again occurs as testosterone goes up. And then other changes that can obviously be seen at puberty is going to be skeletal linear growth. They get taller, they develop higher muscle mass, but if there's, so it can influence the abdominal visceral fat. Usually is if there's not enough testosterone, then men tend to develop more abdominal visceral fat. Higher levels of testosterone can also cause higher levels of red cells, so that's intimately linked. And if you have too much testosterone, then a person can have too much red cells too. And then in the liver, it will increase VLDL, LDL, and decrease HDL, which is not the favorable outcome here for the lipids. If you need more on that, you go back to the lipids chapter. Okay, so this is a little exercise from my class. I'm going to skip that. Okay, so let's talk about infertility. So primary infertility are couples that have not had any successful pregnancies, even though they've been trying. Secondary infertility is a couple that has had pregnancies, conception, but are currently unable to conceive. So something's changed. They are often caused by dysfunction in the hypothalamic pituitary gonadal axis, meaning there's a dysfunction usually somewhere in this domino effect of hormones that we've been looking at. So let's look at a case to illustrate this. So we have 26-year-old Fred and 24-year-old Jonna. They are unable to conceive. They have had unprotected intercourse for about 18 months. So that's usually what we want. We want a year and a half of trying with no resulting pregnancy. Both are avid runners and participates in marathon 4 times a year. So this is something that it needs to be considered because in some cases excessive exercise can interfere with the fertility in females. So Fred's fertility workup is completely normal. So what really does that mean? It means that they did a semen analysis on him, and there is plenty of semen, there's plenty of sperm, and they're motile, and they're moving around, and so he actually is making enough. And so that's a good place to start. Okay. Jonna's workup comes back with an FSH level of greater than 40, so this is quite elevated. And she had an FSH drawn a month earlier with the same result. So we have 2 FSH levels that are higher than expected. So this meaning it's a follicle stimulating hormone, meaning she's producing a lot of that. So the pituitary, the body is trying to stimulate the ovaries to ovulate, to make the eggs to mature up the eggs. And as we've seen in other endocrine stuff, if a stimulating hormone is high, it usually means that it's not being successful at having its outcome of stimulating that egg production. So what condition do you think might account for this, and should more tests be ordered? So here, what condition accounts for their ability to conceive, inability to conceive? So we have 4 choices. So first of all, amenorrhea would be just not having a female cycle or period. So I would imagine that would have come up in the 18 months they've been trying if she wasn't having a normal cycle. So we could probably rule that one out. So then we have hypogonadotropic hypogonadism and hypergonadotropic hypogonadism. So again, your gonadotropes are LH and FSH. Is it too low or too high? So we know it's not too low because her FSH was high. So it could be over here, or it could be primary ovarian failure because of the high FSH and the ovary simply not responding. But to really be able to tell, you do want to do some more tests. And so, yes, I would definitely order some more tests. You would want, I'm going to show you the workup for fertility for females, and so you want to investigate just a little bit further. So let's start with male infertility, even though in our case the guy was normal. So basically there are several causes. Any condition that can affect testosterone levels in a male can cause infertility, meaning if they don't have enough testosterone, there's not going to be enough for it to combine and to work with FSH to cause spermatogenesis, to create sperms. A common cause of male infertility is going to be congenital, idiopathic, hypogonadotropic hypogonadism, meaning they're born with it, we don't know what causes it, and the gonadotropic hormones are low. So the LH and FSH are going to be low, and that is why they have hypogonadism, or their testes are not working. Okay. And hypogonadism, so failure of those testes to work, could be congenital, they can be born with it, or acquired. And we're going to look at some of the different causes. Acquired, I mean, who knows, different chemical exposures, drugs, something's messing with it. So how do we evaluate male infertility? We definitely start first with a semen analysis. If needed, we can do hormone levels. You would want to see free and total testosterone, FSH, and LH, and potentially do an anti-sperm antibody to see if something is neutralizing the sperms and keeping them from fertilizing an egg. So here is a typical workup for male infertility. So worth noting that first a history and physical exam is done. If that is abnormal, so if there's other things going on, if they have high blood pressure, if they have type 2 diabetes, if there's other chronic diseases, then you really want to go down that road first, because that could just be the underlying condition. As a rule, when things of the body, your body has to be healthy and balanced really for reproduction to happen optimally. And for survival, reproduction is not necessary for the being's survival. It is obviously necessary for the species' survival. So we do have very strong drives to reproduce. But if the body is not healthy enough, especially in the female, to sustain a pregnancy or for reproduction to happen, then things will interfere with that. And because it's just not a super high priority. So let's say everything is fine in a physical exam, do a semen analysis. If it is normal, then maybe do some postcoital testing to see if there's something that's killing the sperm after they've been released in the female. Is there any anti-sperm antibodies? Can the sperm penetrate the mucus, etc.? So go into that. But if the semen analysis is abnormal, we're going to go ahead and repeat it. And of course, if it's abnormal again, then we're going to look at hormone levels. So we're going to do LH, FSH, and testosterone. If they are all decreased, then it would be hypothalamic or pituitary failure. So the hypothalamus or the pituitary, either one is not working. Could have been damaged, right? Blow to the head, something could have damaged the pituitary. And so there's no production of LH and FSH, and therefore anything downstream of that's not going to be produced, including testosterone, because there's no LH, and sperm, because there's not enough testosterone and not enough FSH.
Okay, so then if we see high in all of them, so high LH, high FSH, and high testosterone, then it's a gonadal failure, so a testicular failure. The testicle is simply not responding to the stimulating hormones that are being produced, those gonadotropins, and they're being produced, obviously, if the LH is high, the testosterone is going to be high. Now, if the LH is normal, then you would expect a normal testosterone because, again, one drives the other. But the follicle stimulating hormone is increased. Then we can look at it's specifically the germinal compartment, so the stem cells for the sperm, if you will. Those are what is not responding to all the cues that are there for sperm to mature. They're just not. It's just not responding to that. If the LH is increased and the testosterone is increased or potentially normal with a normal FSH, then it could be androgen resistance, meaning just like insulin resistance, the signals, the cues are there, but they're not properly binding on receptors or something, and the messages aren't going through. And then if everything is normal, it's idiopathic, meaning we don't know what causes it, right? Fancy way of saying we don't know. Okay, so then we go to female infertility. So causes can be many and varied. The most common is going to be failure to ovulate, and this can have various causes. A female could also possibly be producing anti-sperm antibodies that could be neutralizing the sperm. So the lab evaluation, again, starting with a medical history physical exam, go there first. If a female has primary ovarian failure, then you would see 2 FSH levels that are greater than 30. This is the case of what we started, our little couple there. Jonna had 2 FSH levels that were actually greater than 40, so she was more likely to have this primary ovarian failure. And we can also assess ovulation and luteal function by doing, again, luteinizing hormones, estrogen, progesterone, and all that. So ovulation is evaluated by progesterone. So that would be the other test you probably wouldn't want to see on someone that's having maybe primary ovarian failure. I would say let's check, is that really what's going on? Are we really not ovulating? And so this is something, ovulation is going to be evaluated by progesterone. You want a progesterone level greater than 4 nanograms per mil. That indicates normal ovulation. This is assessed mid-luteal phase. So again, the female has to know where they're at in their cycle. And so mid-luteal would be when normally progesterone is the highest. And if progesterone is not elevated then there was no ovulation. All right, so again, same kind of workup. We're going to start with history, physical exam, pap smear, etc. Culture, so checking, ruling out infections and all other more obvious causes. Again, if things are abnormal, then you want to follow that line of thinking. We want to, treat infection or do that first. Get the body healthy first. If that's normal, and we evaluate the menses, and so their period, and woman has regular periods, then we're going to go down this line of thought. So we're going to check basal body temperature during the cycle, luteinizing hormone, and then that mid-luteal serum progesterone to check for ovulation. If there's a spike in progesterone at the middle of the luteal phase, then the female is ovulating. Then we're going to look at the postcoital test and see if it's normal. Keep trying. And if it doesn't happen, go see a specialist. If that postcoital test is abnormal, so there's anti-sperm antibodies or there's something going on, could be that there's a problem with the male or there's other factors, and try to track down what's going on there. So if she is not ovulating, she's an ovulatory, do your progestin challenge. And this is a synthetic progesterone. If the response to progesterone is normal, then they may consider ovulation induction, and it could be that the female has a resistant ovary syndrome. If the progestin challenge is abnormal, so the body is not responding to progesterone, even though it's a synthetic one, then we need to see if there's other underlying hormonal conditions. So is TSH, what is a TSH normal or not, prolactin, testosterone? and luteinizing hormone draw all the dose to differentiate between hypogonadotropic or hypergonadotropic hypogonadism, hirsutism, virilization, luteal phase deficiency, or something else. Again, if they have irregular menses and they do a progestin challenge and it's abnormal, again, you're going to go down that pathway of chasing some of the other hormones. Part of it, I want to point out, I've got this from Sarah Gottfried, is that for reproduction, this is like the triangle of like which one's most important. So cortisol levels are going to dictate what's going on with the thyroid and metabolism, and what's going on with the thyroid is going to be dictating what's going on at the reproductive level. So basically what happens is if there's a lot of stress and a lot of cortisol, then the thyroid is going to be suppressed and estrogen is going to be suppressed also. And so sometimes the problem is what we got to fix is here, is at the cortisol level or at the thyroid level. And so if there are issues here, a lot of times it can be manifested in the thyroid. And so that's why we want to track this down first, and, you know, stress management, etc., before we really dive deeper into the estrogen problems. So first kind of disorder or condition, amenorrhea. So this is not having a period, not having that bleeding, that cycle. Primary amenorrhea would be due to genetic conditions or hypothalamic dysfunction. So there's a hormonal problem. So it's not cycling the way it's supposed to, according to the patterns we just looked at a few slides ago. And then secondary amenorrhea is going to be secondary to chronic medical conditions, eating disorders, depression, exercise, etc. So something else is causing it. You always want to do pregnancy test first to rule out that as a cause of amenorrhea, because when a woman is pregnant, her period stops, and that is really going to be the most common cause of a period stopping. It's going to be pregnancy. But then if that is negative, we can do further lab tests. So again, evaluate TSH, FSH, and LH. And if a chronic disease is suspected, then maybe a SED-rate, CBC, liver function test, sputum and creatinine, urinalysis. So again, investigate the chronic condition first. Although other hormone studies can be performed as well, estrogen, progesterone, etc. Depending on, again, you have to interpret all of those within the hormonal cycle. Hirsutism is a condition of excessive hair growth in women, especially if they're starting to get like facial hair like a man, you know, in the chin, over the lip and stuff, and there's just too much of it. And so it's usually caused by increased androgen levels. And androgen excess is often caused by severe insulin resistance, so type 2 diabetics, androgen-producing tumors, menopause, and polycystic ovary syndrome. The lab testing can confirm excess androgens and can also identify the source of the androgen, which could be either adrenal or ovarian. So if a woman has elevated DHEAS levels, then that would be an adrenal source of excess androgens, and that would be where to go look. Kleifelder syndrome is a genetic disorder. It leads to hypogonadism and infertility in men, and instead of being XY, there are XXY. So to have 47 chromosomes, it's karyotype 47 XXY is what it is. And so it's a form of primary testicular failure, and the way you diagnose it is through cytogenetic testing. Kallman syndrome is a rare genetic disorder in which you have a gonadotropin-releasing hormone deficiency. And interestingly, the hallmark finding is going to be hyposmia or anosmia, meaning a problem with the sense of smell. The reason being is the little baby boy fetus, the development, the specialization of tissue, the cells that happen of the cells that make the gonadotropin-releasing hormones and the sense of smell, it occurs on the same day. And so if there's a problem there, it affects both. And patients that have idiopathic hypogonadotropic hypogonadism usually have a normal sense of smell. Patients that have Kallman syndrome have no smell or a very diminished sense of smell. So males with Kallman syndrome or idiopathic hypogonadotropic hypogonadism will have low levels of both free and total testosterone, and females can have low estradiol levels. So again, they're hypogonadotropic, so those gonadotropes are not made, so LH and FSH are just not being made, and that causes the gonads, testes, or ovaries to not be working and not be releasing testosterone or estradiol if it's a female. Architis and epididymitis. So architis is an inflammation of the testes. It is caused by viruses or bacteria. It is most commonly caused by mumps. And so this is here, testicles there. And epididymitis is going to be inflammation of the epididymis, which is the portion right here. It is likely caused by an infectious agent. And so obviously then you'd want to do urinalysis, CBC, urethral culture, and syphilis and HIV testing to see what the organism, the infectious agent is. And treat that, obviously. Menopause is when the circulating reproductive hormones in females decrease, the menses or the periods cease, reproductive capability ends. There is a perimenopausal period that is kind of leading into it where changes are starting to be more obvious, hormone levels are starting to decline, periods are becoming maybe irregular or lessened, and it's essentially a state of estrogen deficiency, which then puts a woman more at risk for osteoporosis. The high FSH levels are going to be the diagnostic marker for basically for ovarian failure, just in our case, except that this is in older women and is expected. So you would not expect this in a 24-year-old, but you would expect it in somebody that's older and more advanced in age. So the LH levels are going to be elevated as well, but they are not needed to diagnose menopause. Polycystic ovarian syndrome, also known as Stein-Leventhal syndrome. This is characterized by insulin resistance and high insulin levels. Again, associated often with type 2 diabetes, excessive androgen hormones, so then they will have the hirsutism that we just talked about, possibly have facial hair. They can even have male pattern baldness going on. There will be high lipid levels with a high risk of cardiovascular disease, high LH levels, which lead to high testosterone and androstenedione levels. Again, giving, you can even have sometimes a deepening of the voice and stuff. So that leads to some male pattern things going on. PCOS patients can have abnormalities in the metabolism of androgens and estrogens, and in the control of androgen productions. So you would want to assess total and free testosterone levels and androstenedione, FSH, and LH. So the few procedures we're talking about measuring testosterone. So free testosterone is freely floating in the blood is unattached to protein. It normally would be attached to protein because testosterone is lipid soluble, meaning it's not water soluble, right? And blood is mostly water. It can travel weakly bound to albumin or tightly bound to sex hormone binding globulin. A total testosterone can be performed by immunoassays or liquid chromatography mass spectrometry, and free testosterone can be done by radioimmunoassay. The sex hormone binding globulin can be measured by immunoassay or by liquid chromatography mass spectrometry. And there are also panels are available that will give you the total testosterone, free testosterone, sex hormone binding globulin, albumin, and the bioavailable testosterone. Dehydroepiandrosterone, or DHEA, and its sulfated conjugate DHEAS can be used and measured to gauge the production of the adrenal androgens. And they are both commonly performed by an immunoassay. 17 ketosteroids in urine are the metabolites of testosterone. They are secreted both by the testes and the adrenal glands, and this is because in females make testosterone too, and so in males, and so we have sites of production in both. They are decreased in primary hypogonadisms, but increase in testicular tumors, adrenal carcinoma, and adrenal hyperplasia. So this is a specialized testing, reference lab kind of question, kind of test, sorry, it's not a question. So what would be a symptom of low testosterone in men? So I'm going to give you a few in case you didn't know. So like depression is one, low energy is another, loss of muscle mass with weight gain, trouble concentrating and stuff. So those are all symptoms of low testosterone. Moving on to the females, estrogen and progesterone. So estrogens, and there's several of them. So we really have three main forms. If you don't remember three of them, that would be great. We have estrone, which is E1. This one is actually the most biologically active, and it is produced throughout the life, even post-menopause. Estradiol, which is the one that is tied to reproductive cycle and reproductive years of a female, and so that's E2, estradiol. And then estriol, or E3, is the estrogen that is produced during pregnancy. So most common methods to assess your estrogens are going to be immunoassays. The most accurate is going to be gas chromatography, mass spectrometry. And your reference range are based on the menstrual cycle. As you saw, these hormone levels definitely vary depending on which day of the cycle a woman is in, so that requires accurate documentation there. Progesterones the progesterone level are used to evaluate ovulation. The level will rise after ovulation with a mid-luteal cycle peak, and then they will decrease then if pregnancy does not occur. The immunoassay is the most common method used to detect progesterone, and progesterone levels are often ordered along with HCG if there's a suspicion that a woman might be losing a pregnancy, because progesterone is needed, especially early on, like if you want to catch an early miscarriage. It's needed early on before the placenta is fully developed to maintain a pregnancy, and if a woman cannot produce enough progesterone, then that woman might be prone to early miscarriages. And some of that can be remedied with progesterone injections. And so, again, those can be ordered with HCG if we're looking at a potential early miscarriage. LH and FSH. There is a mid-cycle surge of LH which causes ovulation. Catching that can help confirm when ovulation should occur. FSH, again, controls the development and maturation of the follicles, will be higher in the front end of the cycle in that follicular phase. For these two hormones, their alpha subunits are identical, so you have to be able to measure the beta subunits to be able to tell LH and FSH. The reference ranges are based on the cycle, so depending on where the female is, which day of the cycle the female is in, and these are done by immunoassay or liquid chromatography, mass spectrometry. Okay, and last old question, do you know what can cause estrogen dominance, which is basically too much estrogen in relationship to progesterone, and that could interfere with fertility. And basically the most common cause is going to be exposure to xenoestrogens, which are compounds that mimic the effect of estrogen and can bind on estrogen receptors. And they're present in our environment, in our water, and plasticizers and everything. So look up xenoestrogens and BPA and you can get an answer to that. And so next we're going to talk pregnancy, but I'm going to put that in the next video. So I'm going to separate these two lessons. So just be looking for that. And if you have any questions, feel free to put them in the comments. I'll be looking for them. And thank you for your attention.